hope everyone can see that. Again, as Mike said, I am a colleague of his at the Institute for Social Research, and will tell you a bit about one of the large studies, as Mike mentioned, large and ongoing studies, data collection efforts at ISR, the Health and Retirement Study. Again, as Mike said, I'm happy to take questions through the chat at any time for clarification, and then we'll talk some more about, or open it up for questions when I'm done in about 30 or 40 minutes or so. All right, and first, thanks to Amanda Soniga, is one of my colleagues on the HRS. She provided a number of these overview slides for the HRS that I'll be showing tonight. The National Institute on Aging is our main funder. One of the NIH institutes has been funding most of the HRS since 1990. Social Security Administration also provides some funding for the HRS. Thanks to the great colleagues. This is a huge team and great colleagues that I've been working with now for 25 years or so on the HRS. And then obviously our HRS respondents, the folks that take a few hours every couple of years to be part of the study and provide information that we hope is useful for researchers around the world. All right, to dive in, and I should say this will be a very kind of 30,000-foot review of the HRS. I'll show you the websites where you guys can go and dig in if these data do seem as though they might be useful for you. All of our data, I should say, are publicly available, and you can get them at the HRS website. And again, I'll provide some more information about that a little later. So to start at the beginning, the HRS was actually created by an act of Congress in 1990. Congress had the aim of increasing the data available to study retirement as the baby boomers were sort of entering their 50s and getting toward retirement age. So sort of directed the NIH to develop a study to gather that information, and the HRS resulted from that. It was the first longitudinal study to include both economic and health information in the same survey, which was sort of innovative for longitudinal studies at that time. There's been 3 directors of the study. Tom Juster, these are all folks, again, who were based at ISR. Tom Juster started off as the principal investigator back in the early 90s, then Bob Willis, and on to David Weir, who's the current director of the study at ISR. We have about 16 collaborators and co-investigators from across all disciplines. Again, I'll show you the wide range of data that we collect. As Mike mentioned, I'm a physician and sort of focused on the health side of things, which will, you'll see the bias in my talk here. Some of the research I'll show as examples, pretty much health-related research. There is a sort of online bibliography at the HRS website where you can look up the thousands of papers across all disciplines: economics, psychology, demography, etc. Again, it's a large study. I'll tell you some more details about that. And again, funded by the National Institute on Aging and Social Security. Again, the basic design is it's a nationally representative study of the population over age 50. We enroll people now at age 51 and then follow them until their death. If they agree to stay in the study, most of them do, so that's a good thing. We also administer the full survey to the spouse or partner of the HRS respondent who's enrolled in the study. And then again, to keep the study representative of the 50+ population, we enroll a new 6-year birth cohort, 51 to 56-year-olds, every 6 years. Again, I'll show you a little more about how that works. And again, there's about 20,000 respondents in each wave, every biennial wave. And about 43,000 people have been a part of the study at some point since it started in 1992. All right, so to again, just show you a bit more about some of the details of who's in the study and the timing. In the first wave of data collection was back in 1992, and that was just the 51 to 62-year-old folks in that very initial wave. Older adults, 70 and older, were sort of added in 1993. And then at 1998 is when sort of the gaps in the age distribution were filled in. And since 1998, the HRS has been representative of the 51 plus population in the United States. And you can see the birth cohorts here, again, enrolling every 6 years, 1998, 2004, 2010, 2016, and now we're actually in the field right now enrolling the new 51 to 56-year-old or early Gen X cohort that was born 1966 to 71. I started working with the HRS team back in 1997 when I was 34 years old and sort of viewed the HRS as studying these very old people. And then I became eligible for this study about 8 years or so ago, and going to turn 60 at my next birthday. So everyone is seeming much less old in the HRS cohort now. We've had good response rates for the HRS study. You can see these are the sort of entry response rates in the first wave, 82% or so in that original cohort, down to 70%, the lower response rate for this is the war baby cohort. And then again, very good retention in the study, as you see here, near 90% for the HRS cohort, and even higher in some of the other cohorts. Like all longitudinal surveys, it's getting harder and harder and taking more and more work to keep people in the surveys longitudinally, but our response rates have remained good, sort of in the 80 or higher percent recently too. All right, to say a little bit more about the study design. Early on, all of the entry interviews were done face-to-face, but then telephone was the primary mode for follow-up. We sort of tried to have all of older folks, 80 plus, interviewed face-to-face. And then we've now, starting in 2006, have gone to a strategy of trying to interview about half of the sample face-to-face. And at that point, we do some additional data collection on physical measures and biological measures. I'll tell you more about those in just a bit. And then the other half of the sample is followed by telephone there. So just to lay that out a bit more specifically. So for instance, in 2006, the first random half of the sample was interviewed face-to-face with the enhanced data collection. 2008, the next or the other half of the sample was then interviewed face-to-face, and then, then 2010 flipped back. So again, every 4 years, the half of the sample has this additional data collection with biological information and physical function information, again, starting from 2006. We've also now include a internet or web-based interview starting in 2018. This wave, about 5,000 or so of the respondents will have their main interview by the web. This is obviously not the half of the sample that's interviewed face-to-face. Lots of interesting methodologic issues, obviously, in web data collection and how those responses compare to other modes of the survey administration, whether face-to-face or by phone. A few other important details to keep in mind. We do what we call both a respondent level and household level data collection. So again, if there's two people in a household, both of the individuals are interviewed, asked about their health and economics. Again, I'll tell you more about what we ask about. But then one of the respondents in coupled households is sort of designated the financial respondent, the person who's kind of tells us they're most familiar with things like income and assets and financial related questions. The other respondent gets the sort of questions on family and transfers and caregiving and kind of interactions among family members. And again, both individuals answer questions about themselves at the respondent level. Important design feature for longitudinal studies of older folks is trying to recruit proxy respondents. So as individuals get older, frail, may become cognitively impaired and are no longer able to provide answers to the survey because of those issues, we try to recruit someone who's knowledgeable about that person. And at any one wave, about 10% of the interviews are done with proxy respondents. That's obviously increases with age, but again, an important methodologic issue for trying to reduce dropout from the survey by at least obtaining information from a proxy. Those original, the 51 to 56-year-old folks that we enter into the study every 6 years are recruited just from the community. We don't include people, we don't originally sample people from nursing homes, but then we follow individuals into nursing homes as they move and age after entry. And then we also do what we euphemistically call an exit interview. That's after someone dies, we try to go back to their spouse or a child or someone who knows them well to ask questions to get a better sense of how the end of life was for that individual. Things like health problems, healthcare utilization, advanced care directives, more things about financial issues at the end of life, and all of that information is available in the HRS data also. All right. I will now dig in a little bit deeper about the kinds of information and domains of data that we collect in the HRS. Again, the sort of big picture of what we do and what kind of information we collect. The core survey, as I mentioned, takes place every 2 years, and that's anywhere from a 1 to 3 hour interview. Again, it's the main, the bulk of the survey data collected during that core survey. And again, it's sort of in the range of about 20,000 people at each survey wave. We also do, we call experimental modules at every wave. And these are sort of short, about 3 to 4 minutes of data collection at the end of the survey, and we put out a call for interested researchers to send us ideas about these modules. Again, they've been on quite a range of topics: economic issues, facility with numbers, end of life care, nutrition issues. You can again head to the HRS website to see, and yeah, I would certainly invite folks, if they do have ideas for limited 3 to 4 minutes of survey and data collection, that obviously you can link with all of the other HRS information. Again, if you're on our email list, you'll get a email announcing the call for these experimental module topics. That enhanced face-to-face data collection that I mentioned, again, we do things like ask people to walk and get up from chairs and balance. We also, again, starting in 2006, started to do blood collection. First, a dry blood spot. More recently, starting in 2018, a full venous blood collection where we collect tubes of blood and look at lots more blood biomarkers from those blood samples. And again, that's the alternating half of the sample gets that enhanced face-to-face. We also do a number of supplemental studies in the year between the core surveys. I'll show you a bit more about those, what we've done on in terms of supplemental studies in a minute. And then one of the innovative aspects of the HRS is that we link to different kinds of administrative data. And again, I'll tell you some more things like Medicare data, Medicaid data, Social Security earnings records. We've done a linkage to people who get healthcare within the Veterans Affairs healthcare system in the United States. So by linking both survey information and these administrative records, you can do many more things than you can do with either set of data alone. And I'll show you some examples of that kind of research in just a bit. Oops. There we go. So here's the main content areas that we collect data on, either by survey or other methods. Lots of questions about health. You can see there health behaviors like smoking, drinking, and exercise. We do cognitive testing to get a sense of how people's memory is working and other cognitive abilities. Lots of questions about health care utilization, employment, economic status. Lots of information about who's helping whom within the family, and both with money and caregiving time. And again, you can see other topics there. A little more on that enhanced face-to-face survey. We do, again, test people's grip strength, ask them to walk, do a test of lung function, balance, take their blood pressure, which I forgot to mention before, measure their waist circumference, which can be important for lots of health issues, hypertension and diabetes and things like that. We've done saliva samples for genetic information, as well as genome-wide association study data, where we, again, get the full picture of key areas of people's genome, things like telomere length, which is a measure of sort of the end of chromosomes that can be maybe important for issues related to aging. And again, all of that genetic and biomarker information is available too. We also do a self-administered questionnaire that digs in a bit more on psychological issues, sort of relationship quality and other things like that. Some of the supplemental studies that we've done over the last 20 years or so. And as Mike mentioned, I've been focused on Alzheimer's disease and dementia in those first two studies, the ADAMS and then the second, the HCAP, or Harmonized Cognitive Assessment Protocol, are two different studies that we've done focusing in on cognition and Alzheimer's disease and dementia. We've done a number of mail surveys. You can see the various topics there: investments in children, sort of more detailed question about consumption and the way people spend their time, what activities they're doing, diabetes, drug use, and again, you can see the various topics there. Again, all of these data available at the HRS website, and again, also the new internet data collection also. Mentioned the administrative linkages, Social Security data, Medicare and Medicaid, VA data, also matched sort of to employers. People tell us who they've worked for. We have additional information on some of the pension plans at those employers, and also the Census Business Register information from there too. COVID, obviously a huge issue that's going to be affecting our lives here in the United States and around the world for probably decades to come, perhaps. And so in 2020, when we had actually just started the field period in March of 2020 when COVID struck, and we had to shut down all of the face-to-face interviews, and we had to pivot to all telephone interviews in 2020 to avoid going into people's homes, obviously. So we also added a whole number of questions to try to get a better sense of people's experience in the pandemic and interaction with the healthcare system. So you can see the types of questions that we added to the survey, as well as to a number of mail surveys. The supplemental study we focused on COVID in 2021. Here's an example of some of the symptom questions that we added to that 2021 mail survey to try to get a better sense of some of the symptoms that are, make up the long COVID array of symptoms, things like fatigue and difficulties with sleep and cognitive problems, breathing, ability to walk, things like that. So all of these data we hope will allow researchers to get a better sense of before and after the pandemic, and among those who either were infected themselves or affected by the pandemic in other ways. One of the very fun aspects of working on the HRS for me over the last 20 years or so has been the increasing number of other countries, international collaborators that have fielded studies, longitudinal aging studies, kind of patterned on the HRS model, similar sampling and questionnaires and methods for the study, with the idea, obviously, of trying to collect comparable data that will allow us to compare aging and health and family interactions in countries around the world. So you can see the studies, a number of the studies that are ongoing now that these data are available to. I'll tell you a bit more about how to get those. Here's a sort of picture of some of the partner studies. Again, the HRS International Network with Brazil and South America, a number of European Union countries, China and India and South Africa. Again, all of these countries collecting data in similar ways. Obviously, the surveys aren't exactly the same, and different countries sort of focus on issues, policy issues, or other demographic issues that are especially important in that country. But in general, many of the studies have very similar domains of data collection, and again, can use those data to compare across countries. The Gateway to Global Aging website is here. I'll show that later, or obviously just Google that, and you can get to a web page that, again, tells you much more about all of the different surveys in the different countries, compares the specific questions across all the surveys, and shows you how to download those data. Just checking a question we got here. Are those participants who died and did not have other family members answer the study questions included in your study numbers as attrition, or are they removed from the total responses? Good question. Yeah, those response rates were for people who are alive. and we're not, I don't think those response rates actually included the exit interviews that that you're asking about here. So yeah, though when people died, they're sort of removed from the eligible sample. Okay. Here is, again, obviously, all of the data are public. We hope you'll take a look at the data to see if it might be useful for the kind of research you're thinking about. Because the data are public, there's been a whole lots of papers and dissertations and book chapters that have been published using the HRS data here. You can see we're up to more than 4,000 journal articles, reports here, dissertations. I think we're getting close to 750 or so total, since these are cumulative numbers here, and books and book chapters. So again, hopefully some of the folks on the webinar here might take a look at the data, and it'll be useful for the dissertations or other things that they're planning. I was now going to, again, just give you a quick review of some of the health and function studies that have been published using HRS data. Might be a good time just to take a pause, and if there are other questions that people want to put in the chat or other things that come up before moving on to some of the studies, I'd be happy to answer those now, or again, we can just plow on and answer or open things up for questions in a bit. Doesn't look like any new questions are showing up, so I will again move on to just a few studies, again showing how some of these data have been, the HRS data have been used in the past. Excuse me, here's a study. Here's a question. Any studies in the Caribbean? Good question. There is a newer study that is going to be fielded in Caribbean countries. It's called the CADAS study, C-A-D-A-S. Again, it is at a link at the HRS website to give you a better sense of that data collection. Puerto Rico, the Dominican Republic, I believe, is included in that study, but yeah, definitely take a look at the HRS website for the CADAS study, C-A-D-A-S, and can get more information on data they've already collected. And again, I know they'll soon be going into the field with a one of these dementia sub-studies to try to get a better sense of cognition and cognitive decline in Caribbean countries. Here, a study done in 2007 by a colleague here at Michigan, Christine Segoli, who's a geriatrician, wanting to look at geriatric conditions, things like incontinence and falling and frailty. Here's where geriatric conditions were defined at, things like dizziness, visual and hearing impairment, cognitive impairment. So very common conditions as people age, but they don't fall into sort of the classic disease model of, say, heart disease or diabetes. It's kind of an accumulation of various problems as people get older. Sorry, the y-axis isn't showing up here, but this is going from 0 to 100%, and the number of or the proportion of people with one or more geriatric condition, you can see gets up close to 80% by age. I believe this is age 90, sorry, our numbers fell off the axes here, but from about 50 up to 90. So you can see these conditions are very common, and they're also sort of independently associated with disability, with the ability to take care of your activities of daily independently. So huge impact on quality of life for older adults, and again, very important related to the caregiving and other support that people need as they get older. Here's another study led by colleague Jack Awashina, who was here at critical care doctor here at the University of Michigan, actually just moved this year, unfortunately for us here at Michigan, to Johns Hopkins. He's done a number of really interesting studies with the health and retirement study, again, showing the value of this administrative data linkage that I mentioned. Jack used the Medicare data to identify people in the study who were hospitalized with sepsis. Sepsis, as more people know now, after COVID, is a general term for a severe infection that ends up causing widespread problems with different organ systems, blood pressure, keeping your blood pressure up, breathing. You start having blood clots that cause problems around your body. Again, this is severe infections, not just COVID, but any severe bacterial infection or viral infections too can lead to sepsis, one of the more common reasons for being in the intensive care unit. So the Medicare data we used to identify individuals in the HRS hospitalized for sepsis, and then all of the survey information on this graph is showing cognition. People who were, we tested their cognition before sepsis. I should show you that these bars show people with moderate to severe impairment, the dark bars here. And these are the two survey waves before sepsis. This is where sepsis happened here. For about 623 individuals in the HRS. And then the first two survey waves after sepsis, you note the large and significant increase in the number of people with severe, moderate to severe impairment, which would sort of put people in the dementia category of having cognitive impairment severe enough to cause disability. So again, there's an example of the sort of value and power of being able to use both administrative data as well as survey data. I have a question here about how does the HRS make sure all subpopulations in the US are represented? Does it oversample minority groups, people living in remote areas, bootstrap weights for researchers? Great questions. Yes, the HRS purposely oversamples African American and Hispanic individuals to increase sample size there. We do sample from all 48 contiguous United States. We don't sample in Alaska and Hawaii, although if people move there again, we follow them there. So there is a good sample size of people in rural areas, although we've had lots of discussions about trying to increase enrollment from rural areas. That's one of the sort of a classic survey sampling issue of it being quite expensive and difficult to enroll those folks. But so sort of balancing the cost and representativeness is a constant issue. I should say we're also, NIA has given us additional funding for this 2022 wave to increase, to sort of do extra oversampling of African American and Hispanic individuals. So we're sort of filling in additional African American and Hispanic individuals across the age range, not just in the 51 to 56-year-olds, but also sort of supplementing up through older ages too, to again, have additional power to look at these key issues of disparities in health and socioeconomic status, etc. Just an example of some of the international descriptive studies that have been done. These, again, we're using data from the HRS in the United States, the English longitudinal study in England, and then the SHARE study is the study in the European Union. And you can see some of the sort of patterns, international patterns in disease prevalence. The punchline here was that basically the United States was sort of worse off in most chronic diseases and ADLs, with England typically being in the middle, and then European Union having the best chronic disease profile. A couple of questions popping up again. Let me take a question here about oversampling of persons of color in the New York City area. Honestly, I don't know the answer to that. If there were some specific focus on New York City, there's obviously a good number of people from New York in the sample, but I'm not certain, and frankly, I don't think there was some specific focus targeting in the New York area. And a question about why aren't Asian Americans oversampled? Oh, and sorry, yes, there are weights, sampling weights are provided for the data. And yeah, all of the HRS data are available to the public. How's the privacy protected? Well, that's a great question. We no identifying information like address or obviously social security number or things like that are available. So we take privacy quite seriously, obviously, for our HRS respondents, and sort of release the data in a way that minimizes any chance for identification. Good question about Asian Americans. Again, a good number in the sample, and there have been discussions about increasing oversamples for Asian Americans, but right now we haven't done that, but it is on the table for potential future consideration to increase the Asian American sample. Let's see others. Great question, Representative of Native Americans in the HRS. Yeah, good question, especially right since Alaska and Hawaii is not actively sampled. Frankly, I think we don't do a great job of supplementing the sample with Native Americans. Again, there are some Native Americans in the sample, but they are not oversampled. So doing studies of specifically focused on Native Americans is difficult, I would say, with the sample size. Although again, for some questions, there may be a large enough sample for depending on what you're hoping to study. Good questions, thanks. Moving on to just a couple more studies to show some examples of things that have been done. We'll wrap up. Here's a recent study of, again, the sort of international comparison question that we just talked about. This is from colleague Hua-Jung Choi in the medical school here at Michigan. And what these graphs are showing, again, this is England, the orange dots and bar. HRS in the United States is the darker color here. And then these are income deciles, with poorer individuals down here at the lower decile, wealthier individuals up here at the top decile. So you can see the general patterns are showing that, again, chronic diseases like hypertension, arthritis, diabetes, much more prevalent in the United States. But the differences across countries get smaller as you get to higher ends of the income distribution. So sort of higher income is associated with lower prevalence across pretty much almost all conditions except cancer. And the differences, the sort of US English differences, are largest among the poor. So again, good examples of how you can use both the health and economic information and the international data to try to dig in on some of these patterns and questions. Again, combining the healthcare utilization and cost information with some of the health information allows you to look at sort of the economic impact of diseases. This was a study by my colleague Michael Hurd at the RAND Corporation that looked at the total monetary costs of dementia in the United States back in 2010, estimated that that dementia costs the United States about $200 billion per year back in 2010, with most of that economic impact being focused on the impact for informal caregivers, how much time that families have to spend providing care to individuals with dementia. A couple more questions here. Let me take a look. Is the reason why the other groups are not oversampled political? I would might need to ask you a bit more to clarify what you mean by that. I mean, I think again, we work with the NIA to try to collect as much data as we can in a cost-effective way, try to oversample underrepresented groups, but again, I think sort of balancing cost and data collection is something we're always focused on, but I do think sampling and including individuals from underrepresented groups is going to increase in the future. So I think that certainly is a priority and focus at NIH and among the research teams. So hopefully we'll be able to do that and improve the ability or increase the ability to do research on underrepresented groups. Question about our caregivers surveyed about end-of-life care needs of people with advanced dementia during the exit interviews. Yes, they are both during the core survey as well as in the exit interview. There's lots of information about caregiving. I mentioned that paper by Michael Hurd, the one that's up on the screen, used a lot of that caregiving information. And yes, the information on cause of death is also, that's one of the linked administrative pieces of data is vital statistics and National Death Index data, where you can obtain information on cause of death. Great question. A couple more quick studies. Again, people have looked at trends in the incidence and prevalence of dementia in the United States. And actually, there's some good news about prevalence of dementia. The proportion of individuals of older adults who have dementia has actually declined in the United States over time, actually in the United States and other high-income countries. But again, unfortunately, with that decline over the last 20 years or so, the disparity, the greater risk among African Americans has remained significantly higher than whites. So about a 1.5 to 2 times greater prevalence among African Americans compared to whites. And again, that has remained constant or so over the last 20 years. So again, important issue in terms of disparities in health in the United States. And then finally, just one other study just to show some of that biomarker data that I mentioned. This is information about antibodies to the cytomegalovirus, which is we obtained from the blood samples in the that I mentioned that we collect. And this study by a couple of ISR colleagues looked at differences across race and ethnicity in antibodies to CMV, and basically the higher values here for African American and Hispanic individuals suggests sort of inflammatory responses that suggest higher stress or lower ability to sort of manage these kinds of chronic infections like cytomegalovirus, which again could be one of the pathways by which African Americans and Hispanics have worse health outcomes. All right, so just again to invite you to go and get lots more information. This was, again, a quick 30,000-foot tour. The HRS website has all the questionnaires and other information. Excuse me. And again, more information for those of you interested specifically in some of the cognition issues. Here's the website that has all of those HCAP studies from across the various countries. That Gateway to Global Aging website, again, you can get all the information on the international data that is available. We've got a help desk, and we do workshops and lots of other ways to get information out. But again, great place to start is just Google the HRS website and go there and check things out. All right. Maybe I will stop sharing there and take some more questions. Looks like we have some more here from Sarah. Research using this data on suicide. Wow, great question. It's a good question. I might go to the HRS bibliography to see if I'm not off the top of my head remembering prior studies on suicide that could be done theoretically with that National Death Index data. But I'm not sure that anyone has done that. Self-inflicted injuries, again, good question. We ask a number, I believe we do ask some questions about self-inflicted injuries or suicide in that psychosocial questionnaire that I mentioned. But honestly, yeah, it's not an area that I've worked in, so I'd really encourage you to take a look at the bibliography and the questionnaires to see if we collect some information that might be useful for you. Let's see. The clinical test measures on cognitive function of older adults in the surveys. Yes, that both in the core survey itself, we administer cognitive testing each wave. It's a scale known as the telephone interview for cognitive status, or TICS. Measures a number of different cognitive domains like memory and language, ability to use numbers and things like that. And then much more in the way of cognitive testing done in those sub-studies on dementia that I mentioned. So, and again, all of the tests are, you can see what the whole protocol is at the HRS website. Let's see, a couple more here. Information was collected about the pandemic. That data currently available. It is. Yeah, we tried to get that information out as quickly as possible. And I believe actually at the website, at the HRS website, there's a specific page on the COVID data that we collected, and it is available. We also collected, I don't think I mentioned, right at sort of late 2020, so before vaccines became available, we mailed a saliva sampling kit to we mailed out 17,000 COVID antibody saliva tests, and to get the antibody status of individuals. Those data I don't believe are available yet, the saliva antibodies, but all of the survey questions related to COVID are out and available at the website. And see, with so many publications, the way to sort through what has been published or used in dissertations by key variables. Yes, so there is, at a great place to start, again, this is a great question, there is a sort of searchable bibliography at the website, and I usually recommend the junior folks I work with that they start there. Basically, you can search on keywords, on topics, on authors, etc. So to get a get an initial look at what are the questions that people have used the HRS data to try to address, get some ideas on methods or questions, hopefully that you can improve on the research that's been done, or think about a new angle. But yeah, you don't have to. I'd recommend starting at the searchable bibliography to get a sense there, and that will then hopefully provide some more direction on things that you can do, and things what variables people have used and things like that. And then there's a concordance app at the website to search all of the questionnaires. So you can again put in a keyword, suicide, for instance, for the prior question, and see if there are any, see where that, if that word shows up in the questionnaire anywhere. And it also gives you across all years of the data collection. It could be that question was asked early on or later, and it'll show you exactly what waves that the question was asked. Data on telehealth, COVID-19. Yeah, great question. We do ask in the the additional COVID data collection, we ask people, so it would be self-report of telehealth information or telehealth utilization. We ask people how often they saw their physician, by what method, was it in person or telephone or telehealth. I'm actually now wondering, I believe once the Medicare data are available for these more recent years through the pandemic, you should be able to, at least for, again, people who are in the Medicare program, 65 and older, you should be able to get telehealth visits from the Medicare data also.
Ken, let me ask you a couple of questions, leading
Sure.
questions for the purpose of clarification.
Okay.
Somebody asked earlier about, privacy issues with regard to the data. And many people think that secondary analysis involves getting a copy of a data set to run your own analysis on. But does the project have an enclave in which people can ask for access to the data to do analysis, but not receive an actual copy of the data to preserve confidentiality and anonymity?
That's a great question, Mike. So we do, at the Michigan Center for the Demography of Aging at ISR, there is a secure enclave and server where some of what we call the restricted data, or the data that are a little bit higher risk in terms of people trying to, say, for instance, identify someone using various types of data, things like geography, where do people live, and by that I mean you can get information on state and census tract, obviously not their specific address, but also Medicare data, healthcare information, things like that. Those data are in the secure server, and you can go and use them there. And there's sort of monitoring of information that comes out of the enclave. There's rules about, for instance, sample size, or cell size, I should say, of results, again, all for the purpose of decreasing the risk that someone could be identified in the data set. And that, the information on that secure enclave is also at the HRS website. Good question.
And there also is in ISR an archive, a storage archive for the genetic data and the biomarkers. And can you say something about why that information is useful generally with regard to studies of health and health
genetic
conditions?
Yeah, genetic data and the biomarker data. Um, so there is a sort of I mentioned GWAS or GWAS, genome-wide association studies, which is a sort of fancy way to say sort of kind of case control studies using genetic information from large populations. So the idea is that you sort of look at the pattern of genes across people's um, chromosomes, identify areas that are slightly different than other people, known as SNPs or single nucleotide polymorphisms, and then see which of those SNPs seems to be related to conditions that you're interested in, things like Alzheimer's disease and diabetes, etc. So that, again, and obviously that was a very brief and you need to get more information, to do those kinds of studies. But that's the general idea of using genetic information. There's also ways to use that, the genetic information, to sort of put together different parts of the genome where there's these SNP differences, and those are called polygenic risk scores. So basically, you kind of add up in some ways. Again, this is a simplification, across the genome, areas that seem to increase risk and create a risk score by combining all of those. And Jessica Fall, who's a colleague on the HRS, and Sharon Cardia, who's a genetic epidemiologist, have kind of led the creation of these polygenic risk scores, which again are for people that don't want to spend all of the time kind of creating these risk profiles, but want to test them in their studies of health conditions or other conditions, and so you can get that polygenic risk information there. Yeah, the biomarker data, again, lots of different ways to use that data. Again, in the area that I work in Alzheimer's disease and dementia, there's lots of interest in trying to understand whether the certain proteins like the amyloid and tau are the sort of abnormal proteins that are thought to cause cognitive decline in Alzheimer's disease, and looking for those kinds of proteins in the blood is a hot area of research right now. Sort of, can we identify who's got elevated levels of these proteins and are they at risk? Can we identify them before they start having cognitive decline and sort of target interventions at them? So those are the kinds of biomarker, or those are potential ways to use that kind of information.
And if a person had the background to design such a study to test hypotheses and so on, this would be another area in which individual information about genomic information for individuals wouldn't be released for confidentiality reasons, but nevertheless, an analysis could be conducted by people in ISR to evaluate hypotheses that people have put forth.
That's right. Yep, absolutely.
See if we have more questions coming. Can you say something about, you mentioned this harmonized data set, I think it was at RAND. This is a way to facilitate comparative data analysis?
Right. Those are at the Gateway to Global Aging website. So actually used to be around, now at the University of Southern California. Jin Cook Lee, who's a economist and colleague, directs that Gateway to Global Aging website. And yeah, I would definitely encourage folks who are interested in international comparisons to start there, because it's an incredibly useful tool to look at these things. Again, things like search by a keyword question, diabetes or hypertension or something like that, and then it will bring up the questions about that topic across all the different countries, and sort of lay them out next to each other, and to allow you to identify what information you have, how comparable is it across the various countries, and yeah, really saves a lot of work in terms of kind of getting all that information in one place. So I'd really encourage people to who are interested in just exploring more about what's available in the various basic things like which countries and what years, and but then digging in more on the specific questions and that you can get there.
Great. We have time for another question or two if people have them. Again, in the chat or the Q&A. Okay, well, I'm going to say, first of all, that we won't have a lecture tomorrow night, but we will on Thursday, a presentation by Joe Saul, who is the privacy officer at the ICPSR, who's going to be talking about conducting research that satisfies HIPAA regulations. This is related indirectly to
very relevant, yes.
the work that Ken does. But I want to thank you, Ken, for a very interesting and informative presentation. We have a copy of Ken's slides, and at the time that the recording of the presentation is uploaded, we'll also make the slides available. But thanks again for joining us tonight, Ken, for a very interesting presentation.
Thanks, Mike. Thanks for the invitation, and yeah, I'd encourage again folks to head to the website and email us in questions, and yeah, love to facilitate the use of the data. So thanks.